Hello, everyone. Thank you so much for joining us today. Welcome to our next AAR Grand Rounds hosted by AMSER. My name is Judith Gadde, and I am a pediatric neuroradiologist at Lurie Children's Hospital of Chicago. And I am, I guess, the first past president of AMSER, and happy to be here and be serving as moderator today. We have two wonderful speakers. The topic for today is from fellow to faculty, taking the leap. Our first speaker will be Dr. Richa Patel. She is a board-certified clinical assistant professor of body imaging at Stanford University. She completed her residency training at University of Washington and body imaging fellowship at Stanford University. She is also currently the Associate Program Director for the Stanford Body Imaging Fellowship. And then we also are honored to have Dr. Cherie Wang here. She is an assistant professor in radiology and a board-certified radiologist with a focus on abdominal imaging and ultrasound. Dr. Wang completed her body imaging fellowship at the University of Washington, Seattle, and completed her radiology residency training in Australia. Dr. Wang is also currently the chair of Equity, Inclusion, and Diversity for the Mayo Clinic Midwest Radiology Department. And just a little housekeeping, feel free to enter any questions or comments you all have. You can use either the Q&A box or the chat, and we look forward to hearing from our two speakers. Thank you. I'll turn it over to Dr. Patel.
Thank you so much. Hi, everyone. My name is Richa Patel. I'm a clinical assistant professor of body imaging at Stanford, and today I'm going to be talking about taking the leap from fellow to faculty, really making that transition. Thank you so much to Dr. Judy Gadde, AAR, AMSER for the opportunity to speak on a topic that is incredibly relevant to my day-to-day life. It is my Roman Empire, if you will. I'm always thinking about it. I'm excited to share my experiences in making that big leap that many trainees, I think, are nervous but really excited to make. And thank you to Dr. Cherie Wang for being my mentor and helping me with a companion talk on this topic. So this talk is really based on my own experiences and learnings. I don't want you to think that this is the only way to make the transition or that I'm the expert. I'm still making the transition myself. This is something that I think every one of us in academics has experienced, and to a varying degree, but we don't really explicitly talk about it. We don't get dedicated teaching on making this transition. And so I'm hoping this lecture will sort of jumpstart that conversation. A special thanks to Doctors Lindsay Negretti and Cookie Menyes for their invaluable mentorship and guidance in tackling such a challenging topic. There's just a few takeaways that I want to reinforce by the end of my 45-ish minutes. The transition is really unique to every individual. We all have different aspirations, we have different life circumstances, but there are so many similar situations and challenges that we encounter. So it may not be vastly all that different to each and every one of us. The challenges you anticipate are, though, vastly different from those that you don't anticipate, and I do want to talk more about those. I've sort of outlined a 5-5-5 approach in settling into your new career, and I'll talk about this later, but it's really about keeping short-term and long-term goals separate and sort of making that transition feel less overwhelming. Community, mentorship, and sponsorship are non-negotiables to a successful transition. These are high priority areas in your work life that you really have to proactively create. And finally, becoming an expert in a clinical or non-clinical area will take a lot of work. But first, a little bit about me. I'll spare you grade school graduation photos here. So I originally hail from Southern California. I went to UCLA where I got my bachelor's in biology. I went to medical school at Boston University. I did my diagnostic radiology residency in Seattle at University of Washington, and then finally came back to California for body imaging fellowship at Stanford. And as a fellow, I really found my home at Stanford. Plus, I think Northern California is just far much more better than Southern California. Some of the hats that I now wear professionally. So I'm a clinical assistant professor of body imaging. I'm in my second year of attending Hood. I'm currently Associate Program Director for our Body Imaging Fellowship, and I've started having more increasing involvement with the Society of Abdominal Radiology. So I'm an early career member of the AAR Inflammatory Bowel Disease Disease Focus Panel, and then I'm a member of the AAR Social Media Committee as well. So I think before we dive into this, I need to really define the transition. So the transition for everyone is different. It's contingent on when you sign your job, what you're doing in the months leading up to your job, and your start date. I'm just showing you my timeline so you sort of get a sense of how things went for me. So my transition seems really straightforward. June 30th, it was a Friday night. I was a fellow. I was on a late call shift. I worked until 9 p.m. I was prelimming reports for my attending, Dr. Luke Yoon, to sign off. And I went home that night, and then I woke up the next day and I was an attending. Boom. And I started work on Monday because it was a weekend. So, on paper, it looks like this was a very short transition, just overnight, in reality, only 48 hours. And so it would seem all my growing up sort of happened in that weekend. It was a very eye-opening weekend, but the reality is that that's just not true. Instead, I think the transition is far more gradual. So in the last year of residency and fellowship, I think is when you really start making that transition into an academic career. You're taking on much more responsibility, you're interfacing with clinicians more, you're really assessing what you know and what you don't know, you're participating in tumor boards. And I think this transition, to be honest, at least progresses into the first 5 years as an attending. I don't have data on that. This is purely anecdotal based on my conversations with other colleagues, and 5 years seems like a solid number. This is also why I really advocate for fellowship prior to work. And that's nearly always the case for those of us in academics anyways. But find a fellowship that really facilitates that transition that you need to make. More responsibility is really key. And it's important to be at a place that is very fellow run and that fosters a lot of autonomy that is incredibly integral to your growth as a radiologist. I went to an exceptionally strong residency program. If you know me, you know how proud I am of my training at UW. And then I came to Stanford, which was an exceptionally strong fellowship. So my residency was very resident run and my fellowship was very fellow run. So I really grew into my own as a radiologist in those last couple years of training. And I think that's really what made my transition so much more smooth. When I started, these are probably the most wise words of wisdom that I've ever received, but I was told my most critical year of training will be my first year as an attending, and that is absolutely 100% true. Okay, so here's what I actually did. It is not overnight. You can see that there were quite a lot of moving factors. I think I was pretty methodical and proactive about it. I signed with Stanford in the fall when I was a fellow, around October or November. So I had about 8 months of advance notice that I was going to be staying. At that point, I was really interested in inflammatory bowel disease, so I asked my program director at the time if I could start getting involved in the Stanford Adult Multidisciplinary Conferences for IBD, which only a few of our radiology faculty participate in. Before the end of fellowship, I was also asked by our division chief, Dr. Aya Kamaya, to be fellowship APD for the coming year, and I think that was a really wonderful offer on her part, and I think a great decision on my part. Having just done this, I think I can offer a more recent perspective, and I really loved my fellowship year so much. I really want to preserve that joy that I felt for our future fellows too. Well, the funny thing is this kind of meant actually orienting our new fellows in late June before I had even graduated my fellowship. So that was interesting. And then July 1st hit and I was terrified, and I think we've all been there. And I think a little bit of healthy fear is very much necessary to making it through this transition. After I started as a faculty, there were also a lot of things that actually helped facilitate the transition. So at Stanford, we cover CT, ultrasound, MR procedures, and fluoroscopy. And I would say as a new faculty, MR, fluoroscopy, and procedures are probably the most daunting rotations, mainly because the workflow is so different. And my division chief, Dr. Kamaya, was really amazing in sort of staggering those shifts. So when I started out in July, my first month, I slowly got into the rhythm of doing fluoroscopy days. And I spent a month kind of incorporating that into my schedule. And then we added on procedures and biopsies, for which I always had a faculty on standby or someone available in case I needed help early on. And then we slowly added on MR. I didn't end up actually taking call until September and November of my first year. And I think having those few months to settle in and adjust and especially get used to the speed and the workflow in terms of reading trainee reports was really critical. And I will tell you that when I took my first weekend call, I had 3 colleagues up front, without me even having to ask, offer to be on standby from home to help if things got really busy and if I got behind. And I think that really highlights how amazing our culture is in our division here, and having that sort of support and that symbiosis with your colleagues is also incredibly critical to that transition. In my first year as an attending, I did a ton of tumor boards early on, which was really fantastic. It gave me a lot of extra cases to look at, a lot of pathology to discuss, and it gave me a lot of face time with our clinicians who would eventually now get to know me as a new faculty. So I just talked about my transition, but there were so many challenges that I think we encounter that I really want to focus on. So these were my anticipated challenges, ones that I knew every single faculty and every trainee is probably contemplating if they are considering a career in academics. Do I deserve to be here? Am I smart enough? Am I efficient? Am I adept enough to handle the demands of work? Do I like research? And if I don't like research, how do I justify my time as an academic radiologist? And then what are my clinical interests, which is a very loaded question, I think, to think of, day one. Now, my unanticipated challenges were a bit different. These were things that I wish I knew or I thought of, but maybe didn't become apparent to me until I actually had the hindsight or until I experienced them. So how do I balance my time? As a trainee, we think we have very little time, but as a faculty, that only intensifies. You are being pulled in so many different directions, and balancing that time is incredibly important. And it's a skill that I don't think we get a lot of practice with. How do we stay productive? So how do I stay productive if I want to commit myself to so many projects? How do I strike a balance between authority and friendship with my trainees? I'm a very friendly person, and I really enjoy being friendly with everyone I work with. And I think work should 100% be fun. It can be stressful and tiring and overwhelming, but it needs to be fun. And I want my trainees to share in that fun every day. But how do I do that while also being their immediate superior? And then finally, the readout. I severely underestimated the difficulty of a good readout, and we will talk about that soon enough. So I asked some of my mentors, my colleagues, my friends who are in academics about some of their challenges, things that they did anticipate. So you can see there aren't too many because I think we all sort of anticipated similar things. This has sort of created like a word cloud. So the larger the font, the more common that topic or that answer came up. So just to start with the obvious answers, efficiency, volume was very much the leading challenge. Everyone thought of that, and everyone anticipated that that would be something they would struggle with early on. Other common things would be the stress of a final sign, being a leader in the reading room where you are now responsible for really setting expectations and handling workflow. Less common things would be providing feedback, being taken seriously by trainees and faculty, especially when you're staying at the same institution where you previously were as a trainee. And then, creating good management recommendations in your reports, making your reports much more clinically actionable than they maybe were before. Okay, so the unanticipated challenges that came up were actually very insightful, and I think this will likely resonate with many of us who are either undergoing this transition or have already made it. Again, the most common being learning to advocate for yourself, navigating workplace politics, negotiating for yourself, recognizing that work-life balance is incredibly integral. So, being a good spouse, parent, child, sibling, fur parent will inadvertently make you a good radiologist. So having that fulfillment in your work, in your life outside of work is so, so critical. And then not knowing how to redirect or how to direct your career initially. So feeling like you need to find your niche on day one, feeling like your initial career trajectory is permanent. But we know that that's not necessarily true. Other less common sentiments, but still ones that I think we can all relate to. You can see how many unanticipated challenges actually came up. It was really interesting to get everyone's responses. Underestimating the value of mentorship and collaboration, especially in academics, recognizing that financial freedom often dictates how much, dictates much of your career, especially how much you work, maybe where you work and live. Understanding the workflow, interpersonal skills, handling failure effectively, realizing that you don't know everything and there is so much more to learn. All these things are really key to making it through the day smoothly. Asking for help on supposedly straightforward cases. We often feel okay asking for help on complicated cases, but what about the really straightforward ones? What if we just need a sanity check from a friend? Learning that spectrum of what is allowable as normal is, I think, really tricky as a faculty. Teaching fellows who are only 1 year junior to you, and maybe you don't feel like you have a lot to offer because of that very small difference in knowledge base. Knowing that your colleagues are actually now competition for local leadership positions. When you're a trainee, your mentor is there for you always, and it's very much a one-way relationship, I think. But when you become a faculty, you, in some respect, become their colleague. You become a colleague of your mentor. So that relationship becomes a little bit more transactional, as it should be. They will offer you mentorship, but they very much have expectations of your performance now that you are working alongside them, or in some cases, working for them. Not having the formal network or protection that we often have as trainees. And then one that I just had to quote because I think it summed things up nicely. So as an attending, you're expected to perform multiple high-level functions throughout the day, and your presence is essential for others to complete their tasks effectively too. All of this to say, I didn't expect so much responsibility all at once. And I think that about sums it up. So my good friend and colleague, Dr. Lindsay Negretti, gave me this idea. So when she adopted her dog, she was given a list of to-dos or goals that were very tangible, and they were organized by days, weeks, and months. So I decided to adopt a similar approach to the early transition, except I adjusted it a little bit. And by the end of this talk, I want to be able to have created sort of a small little task list for any new faculty to maybe consider, and really honestly, just for me to consider. In terms of goals that I can hit at 5 weeks, 5 months, and 5 years from the time I start my job. There was actually a paper that stated that the majority of people who leave academics will do so within 12 years. So you can see how critical the first 5 years in particular and this transition overall is for our new faculty. So as an early faculty, we are surrounded by greatness, right? We have so many people we look up to. We have so many people we work alongside that are experts, that are efficient, that are just fantastic educators, that are innovative researchers. And we think we have to be like them. We have to get from where we are now to where they are now. That's sort of what we think of. And I think, at least to me, there are 3 large buckets of non-interpretive tasks in academic radiology. There's education, where we have to make sure our trainee evals are glowing, make sure we have efficiency in the workroom and that we are teaching. We have research, where we have to publish, we have to get grants, and then we have to somehow establish a local and a nationwide reputation through leadership positions, be invited for talks, give grand rounds, get involved in societies. But I think, it's most important to keep in mind that your clinical strength as a radiologist and your dexterity in reading complex studies and still knowing when to ask for help is really the most important task on your to-do list early on, especially when you're first starting out. You are a radiologist, you are a physician first and foremost, you are a researcher, educator, and expert only second. So when I first started, and even now in my second year, I really focus on the quality of my reports and my clinical time. I think early on, it's really important to preserve as much clinical time as you can, and it's so integral and foundational to your success as a radiologist because a strong clinical acumen does trickle into these 3 big buckets eventually. So focus on your reports, see as many cases as you can, participate in tumor boards, talk to your clinicians a bunch, form that relationship, and understand what they're looking for and what they need to maximize patient care. Okay, so getting into the logistics here, the first 5 weeks, these are my top priorities. First thing, just learn the PACS and workflow. This might be obvious, but if you're at a new institution, it is so important you feel comfortable optimally performing at work. Get to know your colleagues, your trainees, and your staff. Spend time with your colleagues outside of work. Start building that community. Start reading out. It is okay to be slow and intentional. It is okay. Do not worry about volume initially. Just master your ability to read out. And get into the habit of signing most, if not all, of your cases by the end of the day. Get in on time, get in early if you need to, and do keep up reading on your own, not just overreading your trainees. I think that reading a study on your own, which many even academic institutions now encourage their faculty to do because of volumes, it really flexes a different muscle than signing off a report that's already dictated by a trainee. So I still get in most days. I do get in a lot of the days before my trainees even get in. I think the fellow culture of just being on time early in the morning, and I'm a morning person, hasn't really left me. And I try to knock out 1 to 2 studies on my own, and it does actually set me in, on a good trajectory. I feel like I'm really accomplished early in the morning, and I feel like it keeps me more efficient throughout the day. All right, one of the most critical parts of making the transition is transitioning into a position of authority, finding your voice amongst trainees, and really getting over that dreaded imposter syndrome that once, and for me still, kind of plagues us all. So this is the definition by Wecker. Basically, high-achieving individuals have self-doubt about their intellects. They feel like they cannot internalize any success. They're always scared that they're going to be exposed as a fraud, even though objectively and verifiably they have been very successful. And this is a very common situation. You will be plagued by self-doubt. You will wonder, do I deserve to be here? Am I smart enough? Am I courageous enough? Am I confident enough to be at a place like, at X institution? I definitely thought that when I started here at Stanford. And this isn't just a symptom or a syndrome of transition to academics. I guarantee that every trainee in the audience, no matter what level you're at, you have already maybe sensed this. So there was a paper, a really lovely paper written by Deshmukh et al. From Beth Israel, where they actually surveyed radiologists. And they asked them at what point in their careers did they feel like they felt imposter syndrome. And you can see they felt imposter syndrome at every phase of their career, but maximally when they were attendings. And interestingly, this was independent of the number of years of attendinghood. So there was no association with it happening more frequently to junior faculty. They did ask radiologists what they thought was a key contributor, and the most common answer was insufficient mentorship. Bias, inequity, and insufficient knowledge and experience were other contributors as well. The consequences, unfortunately, of imposter syndrome, if they don't go addressed, often are stress, depression, and then people avoiding opportunities or roles because they think they're not good enough. And so they go into a state of avoidance, and that often inhibits diversification, especially at the leadership level. So it is a disservice to not only that faculty, but overall to the department if their faculty are feeling this way. And notably, as we can probably assume, imposter syndrome and burnout certainly go hand in hand. So how can we fix it? So in their paper, they actually offered a medical improv course that helped people kind of get out of that headspace, get a lot of positive feedback. They had an intro lecture on what imposter syndrome was. They got paired with partners. They had affirmation exercises, but some other things that they outlined and some things that I myself have been a part of because I think Stanford in particular really values this. One is formal mentorship. So when I started here, our wellness committee paired me with a chest radiologist, someone outside the body division. And every 6 months, Dr. Emily Tsai and I, we go to dinner. We talk about everything. We talk about our personal lives. We talk about work. We talk about whatever we feel comfortable with. And getting that mentorship from her has been so incredibly vital to me. She herself is also paired with a senior mentor outside of her specialty, which is chest imaging. Having clearly defined promotion criteria for your early faculty is also very important. So at Stanford, every few months, we have Zoom meetings that encourage all faculty across medicine of a certain rank to attend so we can learn about the criteria we need for our next promotion. It's very organized and it's really helpful to know what my next goal is and what I'm sort of working towards. Diversity in leadership is very important. Having individuals from all sorts of backgrounds is so incredibly vital. We need to see, as early faculty, we need to see people in leadership that look like us, that have our background, that share our training, that share our interests, in order to believe that we can eventually reach those positions ourselves. And then finally, celebrating physician accomplishments. It is very hard to want to celebrate a personal accomplishment of your own. I think we are all of a similar mentality in that in medicine. We just don't like celebrating ourselves. So make sure you're in a workplace where others will celebrate you. I get to run the social media account for Stanford Body Imaging and for the AAR Inflammatory Bowel Disease panel. And I love it because I get to celebrate my colleagues. And when the time comes, my colleagues celebrate me. And that symbiosis, again, with your colleagues is incredibly vital. One thing I just want to say, though, that's really important and something that Deshmukh et al. Talked about is that imposter syndrome is not always a bad thing. And it's not something we necessarily need to get rid of. Sometimes a healthy amount of it can actually be very incentivizing. So it's something we need to work on, but not necessarily something we need to completely destroy. All right. Teaching trainees is a lecture in and of itself. I am not a leader in trainee education. In fact, there are leaders far superior to me in trainee education in the audience right now. So I'm just going to do my best, including my co-presenter, Dr. Wang, and our moderator, Judy Gadde. So I'm going to do my best very humbly to try to kind of tell you some revelations that I've had along the way in my 1.5 years as a faculty. So the biggest hurdle to becoming a faculty, I think, is feeling like you have no knowledge to offer. And it is most apparent when you read out a fellow who is just 1 year junior to you when you first start out. It's not as apparent when you read out an R1 or an R2 because they know, what they know is substantially less than what you know. So you have so much more that you can teach them. Plus, when you become an attending, your confidence, I think, does take a hit. You start questioning yourself quite a bit. And at the end of your fellowship year or throughout your fellowship year, your confidence is really peaking. So you as a faculty who is a little bit less confident are now reading out a fellow who is very confident. And so that discrepancy can sometimes lead to a little bit of discomfort. And sometimes with fellows, especially in my year, readout felt less hierarchical, less pedantic, and really just more collaborative. And you might have to ride out those early years like that. You might have, as you become more senior, that delta will eventually grow. And that might not be an issue as much, but I think early on, that's something that you really have to just feel comfortable with, especially with your fellows. The readout, easier said than done. We've all had really, really amazing faculty read us out. We've had faculty who can somehow listen to us, simultaneously review the scan quickly and efficiently, synthesize the material, throw in some excellent, very insightful teaching points, manage to ask us about our weekends because they value us as colleagues too, and then also quickly proof our reports and give us direction on what we need to say. And when I tell you that I severely underestimated how hard that is to do, I am not kidding. My biggest tip in terms of trying to multitask during readout is just don't multitask during readout. I found it very hard. I'm a relatively systematic person and I systematically approach my job too. So, your goal as a faculty is really to be able to review the scan as thoroughly as you can so you don't have to look at the case again before you sign it later. So what I personally do in reading is first just converse with my trainee. I love hearing about their weekend. I love knowing what vacations they're planning, and I love maintaining that relationship with them. And then we get into the meat of it. So I ask them about patient history. We systematically go through the study following my search pattern. I don't let them jump the gun and tell me what they think is going on right away because I personally think it's very easy to get biased sometimes when someone tells you their interpretation of a scan, and then it's very hard for you to see it any other way. Feedback is another challenge. Sometimes so awkward to give, especially if you end up staying at an institution where you were once a trainee, because now you're giving feedback to trainees who simply worked with you as a senior resident or as a fellow. And it's hard to do, and I honestly don't have advice on how to avoid that awkwardness. That being said, give feedback from day one, but make sure it's constructive. Choose your words very carefully. And if anything, I think your feedback will mean so much more to trainees because you are the closest in experience to them and you were just in their shoes. So I think you can empathize more with their situation. When I was a fellow, since I knew I'd be staying at Stanford, I started sort of giving feedback to my residents when I would take over their reports on call. It would be small things, just small teaching points here and there. I would just send them a chat through our packs. And so it didn't feel as punitive. It didn't feel as hierarchical, or it didn't feel like I was trying to teach them something, beyond my means. And then at the very end of my fellowship year in April, I actually gave a lecture to the residents of just common misses that I saw throughout the year when I was on call, sort of like a peer review style. And I think that really helped me assume the role of being able to give feedback even before I became an attending. And I think it actually helped them start seeing me as someone who would give them feedback. And I think it helped them kind of make that transition of me from fellow to faculty in their mind as well. Remember, positive feedback is just as valuable as critical feedback. Recognize also that stylistic changes to reports are just those, they're stylistic. I make that very clear to my trainees. Sometimes I don't give feedback when I'm just editing reports with stylistic things, especially to my senior trainees, because as long as their interpretation is correct, and they often look at the reports later and sort of pick up on some of the stylistic changes, it's fine. I think junior residents in particular benefit from feedback on all accounts. So interpretation, management of workflow in the reading room, running the service, style, syntax, etc. It can seem like there are an infinite number of things you want to teach, but simultaneously as an early career faculty, there's so much you don't know. So one of my colleagues, Dr. Justin Shea, he told me just pick one fact. When you read out, just pick one teaching point that you want to make for that day and just enforce it. And I think that's so true because pretty soon you start accumulating so many different teaching points. And it's a very efficient way to teach. And it's, I think, very tangible for trainees. And then also teach to your strengths. It's okay to do that. So you can guarantee, as someone who really is passionate about IBD, that when there's a Crohn's case or there is a CT or CT or an MR enterography, it is my time to shine. And that's perfectly okay. And the trainees are super excited about that. My trainees know that I love it so much that they will send me interesting cases they encounter, or they'll announce in the reading room, say, hey, Richa, I have a Crohn's case. And so I know to maybe be attuned to reading them out once they're done with it. And that's really vital to kind of building up your confidence in your area of expertise or in your niche. And then finally, formal teaching, a very important part of your work as an academic faculty. At Stanford, all of our faculty participate in med student, resident, and fellow lectures. And a good comprehensive lecture will take a long time to make. I would say 40 plus hours. Create lectures on topics you're either interested in or topics you feel clinically shaky on and you really need to read up on and brush up on. And then repurpose your lectures. So if you're creating an educational exhibit, you just created a lecture. And once you have that, that nice canon of lectures, you can use them and give them again and again, and occasionally just update them with new literature. And then remember to keep your lectures case-based. So the ABR certifying exam as of 2028 will have an oral component. So residents do need to be taking cases. It's really as simple as that. There are some courses that are focused on clinical education. We don't really learn how to teach. And then day one as faculty, we're expected to do it just amazingly, and it's very daunting. So I myself did the Rank and Ray Clinical Educator Development Program that was actually taught by both Drs. Judy Gadde and Dr. Cherie Wang. And it was fantastic. It was in Boston this past spring. And then my good friend here at work, Dr. Negretti, she's actually doing the Harvard Macy Institute course, which is a year-long course as well. The AAR also has an academic faculty development program. RSNA has some courses. CECI2 is another very popular course. So there's no shortage of opportunities to get involved. Another challenge that came up for many folks, I think, that I pulled was involving reports. So there's just a few points I want to make from my own experience about how to handle reports as a faculty. One, it is okay to ask for advice. Find a group of individuals that you can ask for help, ask the experts, share the wealth, share cases. One of my friends recently told me that sometimes he worries about asking others about seemingly straightforward pathology. So I told him, just ask me. It is always less intimidating to ask someone who is just as junior to you or in your league than it is maybe to ask a senior or superior. Number two, sign most of your reports by the end of the day. If you have a report that is not signed for more than 3 days, this is a rule of thumb I got from one of my really lovely friends at work, Dr. Priyanka Jha. If you have a report that is not signed for more than 3 days after you have read it out with the trainee, maybe there's a technical issue, maybe you want to run it by someone, maybe you're still thinking about it, just let the ordering provider know. It is pure agony as a patient to wait for results. Give your ordering provider a heads up that you're still working on it, and then they can manage their patient's expectations. Number three, your report is your reputation. Your report should have no typos. It should be clear. It should be concise. You are a new faculty and your clinicians are only judging you based on your reports. So that really must reflect excellence and clearly reflect what you are thinking, even if you're unsure. And it's okay to edit, like I said, it's okay to edit trainee reports for syntax. I like really short reports, so I find myself often deleting a lot of things, if the report gets too long, just because I want to keep things really concise. And that's fine. And trainees actually really appreciate feedback on that sort of style as well, because ultimately you're teaching them how to be a little bit more efficient in their day-to-day work. Making edits to reports during readout. I'm pretty explicit with my trainees about what should make it into the report and what doesn't need to. Sometimes you'll think you'll had a really outstanding readout with a trainee and then you get the report and it doesn't really reflect what you've talked about. That should cue you to consider that perhaps you weren't clear enough or your trainee may have been confused or not engaged or wires got crossed. So I will try to clarify with them again. And then finally, when I'm actually reading out, I really encourage my residents and my fellows not to edit their report in real time. I find that when they do that, they're not really listening to what I have to say. Maybe they're making edits, but because they don't have packs in front of them, they're not putting measurements in, they're not putting series image numbers in, they're not annotating. So I tell them, take notes at the bottom. Then once we're done reading out, incorporate everything we've talked about and then send it to me. And that really gives your trainee the autonomy and the ownership of their report that they really need to start building. And then finally, signing reports is going to take a long time. I've had colleagues tell me they stayed late, very routinely signing reports when they first started. We've all been there. I think I'm getting more efficient at that. Try to sign off reports in between readouts, especially cases that are fresh in your mind, sign them off. It's also a great way to immediately give your trainee feedback rather than waiting until the next day or that night to sign them off when your trainee is not sitting next to you. I would say that this may be one of the most singularly important parts of making this transition is your community. So the work we do is very rewarding, but it's the people we get a chance to work with that makes it extra rewarding. There are a lot of people you are interfacing with day to day, and you want to surround yourself with people who make you happy and who support you. Spend time with them outside of work. Make a conscious effort to find a group of colleagues that you can lean on because, man, there will be days you have to lean, and that is okay. And you really have to take advantage of being in an academic setting where we can collaborate. Find the people you feel comfortable asking questions to. Sometimes it feels uncomfortable, but that's really important. And know that you will also eventually pay it forward. So this is my community at work. These are my friends both at work. These are my friends, sponsors, mentors, and bosses. And all those lines are very much blurred in the most amazing way. And then I have friends outside of Stanford. I have friends at Penn. Matt, I had to include your formal photo because I don't have a photo of us together. I have a friend at UCSF that I see very regularly. I have friends and mentors in Seattle from residency. That is so, so important. Make sure you spend time with these people outside of work. Many people become friends through work circumstances. So that's a huge plus. And you don't have to see each other every day. You might just see each other at RSNA once a year, but that is sometimes more than enough. And then have fun outside of work. You really need to strike a work-life balance. It is very important, especially now more than ever. Spend time with people who recharge your battery, who help you get through the day. I would not be here without my parents. They are absolutely everything to me. My closest friends from med school onwards have been my family. They are absolutely my family. My grandparents have been incredibly supportive. So make sure you surround yourself with people like that who share that community. I also want to talk a little bit about mentorship and sponsorship, another key aspect of making that transition. I already alluded to it, but inadequate mentorship was cited as a common reason why people feel imposter syndrome. So their mentorship and sponsorship are sort of two ends of a spectrum. Mentors can be more senior to you. They don't necessarily have to be big names or in positions of leadership, though they often are. They guide you, they offer you advice, mainly because they've been in your shoes. You can also have horizontal mentors that are friends or peers, again, in very similar situations. This will help you, encourage collaboration. This will help lessen those feelings of imposter syndrome. They can be local or they can be distant. I have mentors as far as MGH. I think having mentors outside of your institution offers a really unique perspective. They often offer an outside-in view of your career as well, and they can help guide you through that as well. And you can find mentors formally, like we talked about, but you actually really need to just seek them out. Create those relationships with your new colleagues at work to determine who those individuals are that can mentor you. And not everything has to be a formal conversation with your mentor. Sometimes I just text or call my mentors when I need advice. Other times we organize a time to chat. One mentor is not enough. You may not go to the same person for all your advice, but identify strengths and qualities you admire in others that help you, when different circumstances arise. But there's definitely an element of proactivity to this. And people who have mentors, literature has suggested that faculty who have mentors overall have more career satisfaction. They have earlier promotion, they have more publications, they have more grants, they have less burnout. So it is an incredibly, incredibly non-negotiable part of your career. The other end is sponsorship. Sponsors typically are people who have positions of leadership or are experts in their field. The name of the game here is nomination. So sponsors are very well connected. They have no shortage of opportunities coming their way. They're giving talks, they have leadership positions, they have publications, but they cannot always say yes. They have the same number of hours in the day that you do, and they might want to, share a lot of those opportunities with their sponsees. So it's really important for them to hand these off. The important thing to keep in mind is when you are being sponsored as an early faculty, your sponsor is sticking their neck out for you. It is their name on the line. So as a sponsee, it is your responsibility to stay reliable, maintain a good reputation. The onus is very much on you to do the hard work and deliver. And doing a good job often begets more opportunities for you in the future as a sponsee. It's very much a cycle. And these two things, again, are not mutually exclusive. I've had mentors assume the role of sponsors. I've had sponsors then become mentors in other situations. So back to that timeline I had over the last 15 years of my life, what I didn't show you is all the amazing mentors and sponsors that I've had along the way. I've had so many. I have so many more than this. I need to expand this collage. I just don't have photos with all of them. So these are really, really amazing people. These are people who have sponsored or have fostered my intellectual goals. They've helped me realize clinical interests, and they really saw the best in me sometimes when it was hard to see the best in myself. Many of these people were also sponsors at times. They opened the door of opportunities up for me. They gave me talks. They had opportunities for me to publish. They introduced me to others who would maybe foster my interests. So one mentor is not enough. I would argue maybe even here, 9 mentors is not enough. There are going to be so many mentors and sponsors in your life. Make sure you stay incredibly grateful to them, though. It is a tough job to be a mentor and a sponsor. So just keep that in mind. Okay, back to our 5-5-5. Let's focus on the 5 months. So we've settled in at this point. We understand the general workflow of each day. Hopefully we've started taking some call as a faculty. So now's the time you really want to focus on your efficiency and volume. That's when you want to start. Find your mentors and sponsors. That is your responsibility. You have to be proactive about it. You want to assume more graduated responsibilities. So get involved with your division, and we'll touch on that shortly. And then work hard and say yes. About now is when opportunities start coming your way, and try new things. It's okay, to try something and not like it. Okay, how do you become an expert? Very loaded topic. This paper from Radiographics is really great. Regardless of if you're interested in academics or private practice, as a trainee, please read this paper. Doctors Bunch and Tomlinson really hit the nail on the head. It was an incredibly relatable paper. It felt like I was reading my own diary entry or something. So the options for picking your area of expertise, your niche in radiology, are pretty limitless. Radiology has very much diversified in both application and administration, and radiologists are stakeholders in all these facets of radiology. So it is very important. You don't necessarily have to have a clinical niche, but I think most of us gravitate towards certain pathologies that we enjoy studying. And then those of us with non-clinical interests as well still have some clinical interests. So you can have more than one. And it's really important to recognize that the most successful and happy and functioning departments and divisions have people doing a mix of all these things. So if you find yourself in a division that doesn't have people who look like you or match your interests, that's often a good thing. You will bring something to the table that others won't, and you should really own that. We are often, we are after all a cog in the wheel. That's my little, my graphic to represent that. So a couple ways that we can actually we can find our niche. One, self-reflection. You have to be very introspective here. Who are you? What skills do you bring to the table? What do you want to achieve? Who do you want to become in 1, 5, 10 years from now? And what steps do you need to take to get there? 2, I personally think try new things. Find projects that interest you, but also do things outside of the box a little bit, outside of your comfort zone, because that might be a way to actually realize interests. Strike a fine balance. Don't overcommit, but don't pass up on opportunities once you say no, because once you say no, you sometimes aren't asked again. And participating in projects may open doors to interests that you didn't know existed. And then 3, look up to, others that have achieved what you want to achieve. Talk to them, watch them, see what traits and habits they have. This is what ultimately made them successful, and you want to follow those. It doesn't have to necessarily be someone who shares your exact same radiologic interests, but it does have to do with finding inspiration in how they actually approach their work. And then keeping that, keep that in mind, and keep in mind the fact that everyone's career trajectory will always be a little bit different. And when you're thinking of clinical interests, think of what are you actually interested in the reading room? What cases do you enjoy reading? What clinical questions do you end up having at the end of the day? And the same applies for non-clinical interests. What are you intrigued by in the day-to-day running of a department, or in leadership, or in administration? So how do you make your mark? There's so many ways to do this, but I'm just offering a few points that I want to personally make because I found them valuable. Number one, find the untapped potential. So find something that no one in your division is doing. It is better to be a big fish in a small pond. There are certainly certain areas of radiology that are very much saturated, and it is very hard to enter those and become an expert in those because those areas already have a plethora of experts. So look for a clinical need and assess if that interests you. And ideally, it's something that you can really grow into. Do the work. This is the most important. Read the literature. The only way to be an expert in a topic is to be clinically strong in it. While you're reading the literature, turn it into a review paper, turn it into an educational exhibit. It's a way of making your way through literature and somehow getting credit for all that time you're putting in. Teach your trainees, create resident lectures, read more of those types of cases in the reading room. Number three, establish a reputation outside of radiology. So you are only an expert, I personally think, in a clinical area if the non-radiologists view you as one. So the day a GI comes to me and says, Richa, we think you are a Crohn's expert, I will be a happy camper. So for example, in a clinical niche that you're pursuing, get in touch with the ordering providers, participate in tumor boards, go to multidisciplinary conferences, go to their meetings. So for Crohn's, I could go to Digestive Disease Week. I could interface with GIs. I could collaborate with them on projects. In non-clinical areas, reach out to those that are maybe pursuing similar interests outside of your division, DEI, finance, quality improvement, et cetera. Collaborate, right? Collaborate with people inside your division and outside your division. We have a couple colleagues in our division who are giving talks at SAR in a couple months, and they're submitting projects with non-radiology colleagues. They're submitting projects with surgeons, which is fantastic. We need non-radiologists. We need to build that reputation and that relationship with them. They are also very essential, especially at Stanford, for promotion because their opinion really matters. I, this year, for example, collaborated with our Stanford chief of IBD and gastroenterology, and we submitted an educational exhibit to RSNA. Join groups or societies that share your interests. When you have grand round speakers, interface with them, go to the one-on-one meetings, go to the dinners. This was Dr. Meg Lubner from University of Wisconsin. I was a first-year faculty. She is a very big name. I was incredibly intimidated, but we had lovely food and I was surrounded by all my work colleagues, so I was much less intimidated. It is a great way to meet very, very big people as a junior faculty in a very intimate setting, and you have colleagues who can facilitate an introduction on your behalf. So I just want to show you an example of what I've done so far and how these attempts have kind of helped me at finding my niche and how I've gotten here. This does not have everything. There are projects that are ongoing, especially research that I haven't included. Much of the opportunities that I've gotten have been coincidentally they've presented themselves to me. I was interested in them, but I think a lot of it has been based on my personal interests and then also based on merit. So I do think it's really important to be reliable, committed, and involved as a faculty. That is how you get nominated for things, and that's how you build your reputation. So in the second half of my residency, I listened to a really amazing talk from Dr. Ryan O'Malley. I'm sure he would really enjoy the fact that I've featured him so prominently here. He's probably one of the best radiologists I've ever worked with and really one of the most phenomenal educators. And he gave a talk on Crohn's and MR enterography. And since that talk, I really, really liked MR enterography. Bahar Mansouri, who's here in the bottom right, she is one of my close friends and mentors. She introduced me to an RSNA educational exhibit in the last year of my residency, and that won magna cum laude, and I realized I really like educational exhibits. They are so much work, but they really forced me to go through literature well, and by the end of them, you have a lecture too. I also got involved in RSNA case collection. Like I said, I participated now in the multidisciplinary conferences for IBD, and then I became a member of the Disease Focus Panel, which is basically a group of experts from around the country that share my passion for IBD and really do incredible work. There's research, there's reviews, there's courses, there's consensus statements that are put out, and I realized how impactful it could be to work with people who share my niche outside my institution. I got to publish my first paper in JMRI on liver imaging. It was a review paper that synthesized a ton of data, so that was a really good opportunity. I went to the Clinical Educator Development Program since I was really enjoying education. Through the DFP, I got a chance to co-author a really fantastic review paper with a good friend of mine. This is just a screenshot of our proof. Again, it was something I wanted to do because I wanted to become an expert in Crohn's imaging. And if I wrote a review paper, that would force me to go through a ton of literature and synthesize it. And that was incredibly helpful to me clinically as well. Just last month, with a few of my colleagues here at Stanford, I published my first author radiographics article on acute cholecystitis. And I just found out 2 days ago that our Crohn's educational exhibit that was submitted to RSNA this year got solicited for radiographics as well, which is fantastic. It's a topic that's really near and dear to my heart, and I'm so excited to share that with our radiographics readership. And then with our DFP in the coming months, I'm going to be giving a workshop on Crohn's imaging and then helping out with our hands-on course as well. Quick word about society meetings and conferences. I don't have much to say other than go. Submit for talks, workshops, scientific sessions. Find a way to get to these meetings. Time spent outside of these lecture halls is just as valuable as time spent inside these lecture halls. This is where you network. You see your old friends and your mentors. You make new friends and you find new mentors, and that is so vital. Have an elevator pitch ready. People are so busy at these meetings, but they want to talk to you. So have an elevator pitch ready about you, about a project you're working on, and about your clinical interests. And that you want to be able to communicate with them very quickly and exchange your contact info with them very quickly. I personally think subspecialty societies are easy to navigate. So SAR, STR, ASNR, SIR, et cetera, because they're more intimate. You're more likely to see people who match your clinical interests. And then for those who are interested in academics and interested in education, Rank and Ray and AAR have very, very excellent meetings. I think they're very fantastic meetings and really important to get involved with. Okay, just the last few minutes here, productivity. You have to master it. It will make your life easier. Find a way that works for you. We are in a generation of work-life balance, and I want that to be important. That is very important. You have to strike that balance now, otherwise you never will. But I think in a culture of leaning to say no, maybe we've skewed too much in that direction. And I think early on, what I can attribute to my success so far as a faculty in making this transition is that I said yes. I said yes to a lot. Now, I'm not saying yes to everything is necessary, and I recognize that every new faculty has a unique personal life, family responsibilities, and personal interests, but your reputation as a radiologist, as a physician, is your biggest asset. Don't let others down and don't drop the ball if you commit to something. Say yes to things you are at least curious about and stay organized. It's okay to take on a couple responsibilities. You are a cog in the wheel of your division. We do want, in our division, everyone contributing in a different way. But make sure you're managing your time. Be wary of how much time you have and don't let it impact your clinical workload. Again, first and foremost, clinical acumen and your responsibilities as a physician towards your patient and towards your trainees are priority. When I'm on the clinical service, I'm trying really hard now not to schedule any other meetings or any other interruptions. That is really just reserved for academic time. When I am on clinical service, I'm on clinical service. And I have found that very helpful. Creating those boundaries has been very helpful. And there will be times you have to work on weekends. I've spent many a Saturday or Sunday in my local Pete's getting work done. I created this Grand Rounds talk on weekends primarily. It happens. Don't fight it. Don't compromise your clinical work to make time for it. So just rounding out the 5-5-5, 5 years of attending hood. What do you want to do? You're still going to work on efficiency and volume. You're going to find and expand your niche. You're going to expand society involvement and leadership. If you're interested in research, publish, get grants. If you're interested in education, give talks, publish, capitalize on all those things. And I think the most important takeaway here is be proactive, say yes, seek the guidance. Like your training, your career is really what you make of it. And as someone who has benefited from mentorship up until now, I will tell you there is no shortage of amazing, kind, motivating, inspirational radiologists out there who want to help this next generation of radiologists succeed. And that's all I have. Thank you so much.
Thank you so much for that wonderful and helpful talk, Dr. Patel. We'll now turn it over to Dr. Wang.
Hi, everyone. I am just going to share my screen, which I can't seem to find anymore. Share, here we go. Okay, so I am going to talk about aiding the leap. So firstly, the leap is very scary, and sometimes we get dirty and sometimes we fall. So how can more established faculty help those who are transitioning from fellow to attending? So I'm currently an associate professor. I am 6 years out from my fellowship, and I'm going to share with you my top 3 things which I think established faculty can do to help new attendings, whether they're fellows or new to the institution. So these are Cherie's top 3 things. The first one is help them get connected. It is important to get them plugged in very early on, get them connected to others in the division, department, within the institution. And this will also allow new faculty to feel included and foster a sense of belonging. This also allows them to find collaborative sources outside of radiology, which is really important, not just as radiologists improving our reads, but also for academia and collaborative promotional purposes. So this is imperative, especially in the academic setting, because I think junior faculty can find it very difficult to start their own projects, which ultimately leads to publication. So for junior faculty who do not have much experience in publication, it is important to help them on this road, as we know that there are definitely certain expectations in terms of publication at a lot of places. Now, remove roadblocks. So I want to add this extra part, not just remove the roadblocks, but also then get out of the way. I think the remove roadblocks part is self-explanatory. However, what is not self-explanatory is what roadblocks should you be removing. So this is definitely a two-way street. As an established faculty, you need to know what are the aspirations of the junior attending. I think this part requires a lot of trust between the new faculty and the more established faculty. And it may be something you might not develop with someone right off the bat, but hopefully as you progress through the earlier years of being a junior faculty, you can find someone that you can share your, aspirations and inspirations with. The then get out of the way part, I think, is more nuanced. There's a reason why we hired a person, right? They're obviously someone we think is great and can do great things. So let's not micromanage new attendings. Give them the space that they need to find themselves. And guidance is great, but the rule of thumb is be a gardener and not a carpenter. Let them cook. Sure, sometimes they may fail at an endeavor, but this can be good for them and allows them to find their own way. The mentor, sponsor, and advocate part, we can all get behind. And I'm sure we can all think of someone who have mentored, sponsored, and advocated for us during our careers. It is very important to pass that forward to continue the lifeline of radiology. I want to talk about protect. So junior faculty can be the targets of bullying. So one example I can think of is when referring clinicians see a new name at the bottom of the report. They can become cynical about this new staff and, oh, I've never seen their name before, so I don't quite trust them. So I don't actually think this only happens to junior faculty. This scenario can indeed happen to senior staff who are starting at new institutions. So it is important that we keep this in mind and help new faculty navigate this period of time, which can sometimes really trigger or add to their imposter syndrome. How to avoid these situations is by helping your faculty get connected to referring physicians, which we already have discussed. Now, my final thoughts on this. As an established faculty, there are going to be new attendings and junior faculty who do not want or need your help. And this is completely okay. And do not take this personally. This oftentimes has nothing to do with you, but rather where the junior faculty is at that point in their career. But it doesn't mean that during different stages of their careers, they're not going to come back and ask for your support and your help. And when they do, I hope they can really count on you. Thank you.
Thank you so much, Dr. Wang. We are getting close to the top of the hour, but if anyone has any questions or comments, please let us know There was one question in the Q&A, which I answered about the recording. The recording of this presentation will be available hopefully by tomorrow, and it should be available on the AAR's YouTube account, where you can also find the prior grand rounds, and there's no sign-in or anything required. Anyone else have any questions? We had some wonderful comments that were unfortunately only going to the host and panelist. And I think that person has left, but there were a lot of great tips and tricks. One thing that I'm not sure if we had covered, but that person had also put in the chat, was to keep up your CV from the beginning. I still tell myself that every day. I'm like, oh, moderating this, I need to add it to my CV, because if you don't do it soon after you've, done whatever the task was, you will likely forget about it, and then you won't get credit for it. So definitely highly recommend doing that.
And also keep in mind, each institution has their own way of wanting their CV submitted for promotion. It's helpful to just get that template early on and make that CV in that style. Otherwise, you're going to have to convert everything when you submit things at the end of the year. So I learned that the hard way.
Yes, especially important when you're going up for promotion. Michael DePietro, sorry, I might be saying your name wrong. You had raised your hand. Are you able to unmute? Oh, wait, I might have to allow you to talk. There. Now can you?
Yes, hi. Yeah, sorry I sent all that stuff. I didn't realize I could send it to anyone. A couple of the things, just try to summarize it. In programs that are now CAQ, there's a problem because it used to be, well, before we were CAQ, basically, if you had a one-year fellowship, the first half you were sort of as a super resident, and the second half you're sort of as a junior attending. So when you finally left and really became an attending, you had already had quite a bit of practice at it. Basically, the CAQ doesn't let you do that, but it is important. So I find it really useful to try to get our fellows to have some practice with checking out residents and that. Maybe you'll just kind of sit, behind them, kind of keeping quiet, just watching them. But it's a totally different mindset, than just reading yourself. And I think that's an important point. And CAQ programs have to. It should be a part of their plan for the year. So I think that's very important. Another thing I had said was that in talking about being academic, and a lot of it was on publishing and that, which of course is very, very important. I've always found over the years, this is almost 50 years, like being academic is kind of a state of mind. I think it's a matter of being curious, looking a little deeper, knowing your cases, answer the question the clinician is asked. And I always tell them, answer the question they should have asked, not to be a wise guy, but and the knowledge and learning goes both ways. I mean, even still, I learn from my trainees, and if they see that you're together in this process, it's not as intimidating. You're trying to get knowledge, and you're both working at it, and it goes both ways, and that can kind of help with feeling that, because overnight, as the first speaker said, you don't suddenly gain all this wisdom and everything. I had been fortunate to know some of the greats, way in past generations, and they were not afraid sometimes to say they didn't know. I mean, they didn't just raise their, shrug their shoulders and say, you're on your own. I don't know. I mean, they try to help the clinician, but they weren't afraid. They didn't try to make up things. And if they can say they didn't know, I certainly should have no fear about that, because they were a lot smarter than I am. The other thing is surprisingly, as you got to know them, some of them admitted that they got butterflies, which was very, very interesting because it didn't come across that way when they were presenting. But everybody does. Like I say, I'm also a musician, and I know a lot of very, very fine, accomplished principal symphony musicians who said the same thing, that it's a lot of pressure, but that's part of the game. So don't be afraid of it. Reports, yeah, I mean, as long as the resident says what is true, you're certain to the degree that you think is justified. There are many different ways to do it. But I agree that, sometimes with stylistic changes, if you do make a stylistic change, let them know why you're doing it. And they might see your point and they may adapt it. Because I always tell them, over the course of your 4 years, you're going to make your own style that sits right for you, taking what you think is the best from this person, that person, etc. But hopefully, should be something. And then, put yourself in the frame of mind of the clinician. Is it a clear report, etc. And the other thing is about asking questions. And someone was saying about asking your colleagues. If you have really good colleagues, in a way, asking them a question is not a sign of your weakness. It's a sign of your respect for them. And we ask these other stuff. We have like a big reading room. A lot of departments have that, and every other person, they're working at their own station, but they're very close by, and we show each other stuff all the time. And it's a good thing. It's really what makes work fun. Yeah, about the CV, keeping it up to date. You already mentioned that, especially regarding teaching stuff. It's so easy to forget, you did this conference, that conference, this or that, so I used to just keep a little 3x5 card and write it down. And then every few weeks, put it on my CV. But if you didn't do it, you're going to forget it. And when time comes for your yearly review or something, you're going to be selling yourself short. And especially because these days, because the teaching portfolio thing has become a very, very important part of CVs. And I guess that's kind of it. Yeah, I like the analogy that I heard one time years ago that, you have to let your trainees, especially your fellows and that, because they're going to become attendings, get a little practice ahead of time, practicing to be an attending. You can't, what they say you can never learn how to drive a car if you never leave the back seat. You got to do it. So anyhow, those are the things that I had said. And sorry I had to take up your time because I didn't send it to the right group, but there you go. Thank you.
That's okay. Thank you so much for sharing all of your tips with everyone. We do have one question in the chat. Marina is asking, when deciding what task to say yes versus no to, is there anything that should be an automatic no? Is there anything you said yes to that you would not recommend to a new faculty now having that experience?
In my mind, I don't think there's anything that's an automatic no, unless it really doesn't resonate with you. And unless you really don't want to work with said person. I think that is an automatic no. I think as an early faculty, you have to be very mindful of, not breaking bridges in any which way and not ever falling through, essentially, or failing to deliver on a goal. So if you feel like you don't want to work with someone in particular, or there's a topic that is absolutely just not interesting to you, it is okay to say no. And sometimes it's okay to recommend other people. I think a lot of the times we know other people who would really love that opportunity. I think that's a really soft way of saying no, is saying, I won't be able to do it, but I can recommend so-and-so who would be very interested and would be a really amazing candidate. And that's a great way to sort of benefit your colleagues and your friends as well. I haven't said yes, thankfully, to anything that I regret. But I also have had a lot of mentors and along the way that I have chatted with. So right now, anytime I get a big opportunity, I do talk to a lot of my mentors about it, and I ask them how to navigate it. And luckily, they have encouraged me in really lovely ways. So.
Thank you. And I think that also gets to Lindsay Negretti's question about any advice on how to politely turn down an opportunity if unable to commit. So like you said, you know, if there's someone else you can give that opportunity to, that's always an example of you being a sponsor for someone else. I don't know if either of you have anything else to add to that.
One word of advice that I was given in terms of how do you decide what to say no to and what to say yes to? Well, firstly, like what Richa said, you have to want to do it. You have to be passionate about it. That's the first big key. But someone also told me to be very mindful of what I'm doing, because we only have a certain amount of time that we can spare. So a lot of times younger women may be delegated tasks that may not lead to anywhere. So how this person explained it to me was there are different types of leadership roles, but not all leadership roles lead to the place you want, and not leadership roles lead to somewhere. So you have to be cognizant of, well, if this leads to nowhere, but I'm very happy to do it, then you should do it. But if you're thinking, well, my goal is all the way up here, but there's no bridge between what I'm doing to that, then it may be something you have to think about. But I am also of the opinion to just say yes, because I think you actually gain all these knowledge unexpectedly. And I think that serendipity has worked very well for me in terms of my career.
Thank you, Dr. Wang. We have a question in the Q&A. What advice would you give to a fellow seeking a job at their current institution?
Oh, great question. Your entire fellowship year is your interview. I think it is very important to really set the standard for yourself. You are building your reputation now, and you have an idea of the inner workings of your institution. The best thing about it is you know the day-to-day, you know the culture, you know the people well, they know you well. So it's great. I stayed at my institution because I really loved it. And I think if you're seeking a job at your own institution, I think that says a lot about how well you've been treated. And I think you should be super proud of that. Take advantage of knowing that you might be staying and try to see if you can, tailor some of the final few months of your training to help you ease that transition. So I didn't talk about this, but the month of May of my fellowship, I was supposed to do a high risk fetal OB ultrasound elective. I was staying here at Stanford, and I wasn't going to be reading that. And so my program director at the time was able to take that elective and turn it into just a hodgepodge of really important rotations I needed to be on. So giving me a little bit more biopsy practice, giving me some time on fluoro. So I felt comfortable with the workflow here on fluoro because it was different than my residency. So you actually have a lot of lead time. If you are anticipating you're staying, that's really great. And be very transparent with your program director about what your needs are and what you feel like you need. And hopefully we, between Dr. Wang and I, we touched a little bit on what you shouldn't be anticipating and what they can do to ease that transition. But that's great. You should feel very proud. That's awesome.
Thank you. Anyone else have any questions? Okay. Thank you again to our wonderful speakers, Dr. Patel and Dr. Wang. Thanks for all of your very helpful advice. And thank you to all of our attendees and all of your attention, and hope everyone has happy holidays.
Thank you.